So I have got a presentation, I'm afraid, and I thought, spent quite a lot of time yesterday talking about, the process and the inputs and thinking about how we could do things better. But we've done a number of investment cases in the area of mental health now. So partly through your encouragement, Nick, we did do a kind of an analysis that looks across actually 7 of them. So yesterday I put this on Tuesday. I put up this slide just to remind people of the status where we got to, and I'd actually forgotten one of the planned ongoing ones, which is Kyrgyzstan. So if you add all of that lot up, you've got, I think, about 13 or 14 investment cases in the area of mental health. So the ones that are in italics are the ones which we have done this cross-country analysis for, which is ready to go. All the analysis is done, but as we were saying yesterday or on Tuesday as well, we are having some difficulties getting some of these over the line. So until we have the formal approval from the government, some of the colleagues and authors of this article are unwilling to proceed. So this was prepared in sort of October time mainly by Yongyi and myself, and then we sent it around for comments and reviews. So we're just sort of primed and ready, and we hope to get the approval from the different countries to allow us to submit this, because this can help to get the word out. We prepare these reports which go up on the WHO, UNDP, and maybe a few other websites, but not always easy to find. And the benefit, of course, of a comparative analysis is that some trends or some differences come out of that, and you can use that as a basis for discussion and for learning. So I thought I would quickly present some of the results of this and use that as a basis for some discussion afterwards about either the findings, but could also come back to the methods that are used and some of the limitations of the work that we have done so far. So just to situate all of this, if you like, this is the hypothesis for these investment cases, which is that we definitely can say there is renewed or more interest, awareness, and commitment of a political kind to discussing, thinking about developing mental health services and systems. But we can also say that there is a lag in terms of the financial commitment, and that has not kept up with the political commitment to this area. So therefore, a assessment of expected costs and benefits of scaled up delivery of effective mental health services and interventions should be able to inform and promote and guide better investment in public mental health, particularly in those countries which are specifically requesting this type of work. And we basically developed this standardized guidance on the back of the existing NCD one, adapted it a little bit for the mental health area. For example, we have to delve in a bit more into the non-fatal aspects of intervention and benefits, and thinking how to quantify those. So as I mentioned, we've got 7 of these countries in the analysis, and I will show you some results both for the economic burden and consequences, and then the cost and benefits of scale up. in US dollars for easy comparison. So here's the first of the findings. Two things shown here. On the left, it's a breakdown of the absenteeism and presenteeism costs combined, but split by condition. So everything from alcohol use disorder and epilepsy through to a number of severe and more common mental health conditions. And you'll see the way it's been grouped into two groups of countries. These are not geographically defined, which is how we started, but actually it's a split based on the time projection of the work. So the ones on the left had a 10-year time horizon, whereas the ones on the right-hand side, Kenya, Nepal, Philippines, Zimbabwe, used a 20-year time projection. So of course that's rather important, both in you know, as a categorizing variable, because the total costs or even the average cost will be affected by the time period of the analysis. So that's why we split it in this way. And on the right, you've got this time you've got all of those absenteeism, presenteeism costs, but adding in some small other additions. Notably small is the mental health spending in these countries, almost invisible in Bangladesh, as you can see. Just looking at these categories of costs, so splitting up, for example, the presenteeism and absenteeism. They're just a different way of showing almost the same numbers. And you can see that when you do that, the costs, this is expressed in millions of dollars per 1 million population. So in simple terms, per capita or per head of population. And you can see in some countries, and many of the countries, it's 10, bless you, 10 or more dollars per capita is the estimated economic consequences of these conditions when combined. Moving to the costs and effects. So this is closest to the cost effectiveness analysis that's been conducted through WHO's Choice program for many years, as well as other national or international cost effectiveness analyses using a cost per DALY or cost per QALY type framework. So here you see, if you keep in mind those costs, I was saying 10 or more dollars per capita, here you can see what is the cost per capita of scaling up these interventions over these periods of 10 years, or in the second group of countries, 20 years. You see quite a variation there. Again, this is split across the different disease conditions that were included. And you know, some of them get up to about $2.50 per capita. This is per year, and compared to $10 or $15 per capita, that is a lot less, obviously. And the other point perhaps to show here is how dominant some particular conditions were throughout this whole last couple of years. The issue of the cost associated with treatment of bipolar disorder kept coming up in some of these national studies. So we can come back to that perhaps as a discussion point. But and then on the right, you see the impacts of these conditions of the interventions. Again, split. So you can see, for example, that whereas on the left-hand side, the purple is quite substantial, that's the bipolar disorder investment cost. The purple on the right-hand side is very small. So we already see from this that there's not a great ratio of benefit to cost, whereas for something like depression or epilepsy, the costs are very modest, but the benefits are quite substantial. And then when we convert all of these benefits, the health gains and other productivity gains into money metrics, in this case US dollars, then we find that the overall benefits per year, again, expressed per capita, are something like anything between less than $1 up to $3 or $4 per capita, when you include both the health gains and the productivity gains. So overall, we get these kind of benefit cost ratios, and I think the thing to say here is that there is quite a range, both with respect to the countries. If you look at Uganda, for example, you see consistently low. If we just take the bottom hand panel, which is combining all of the benefits and relating them back to the investment cost, you see that consistently below 3, or with only depression is higher than that. Whereas in other countries, we see much more consistently better or higher ratios, including Bangladesh. The other distinction, of course, is by these different disorders. Remember, these are packaged up. I mean, these are already maybe multiple different interventions for these different conditions. And so these are sort of summing up, areas. So we see, again, a huge range across countries, but also within countries, some clear winners and others which are not so attractive. And not surprisingly, the more severe mental health conditions like psychosis and bipolar disorder tend to have lower benefit cost ratios, whereas epilepsy, anxiety and depression, alcohol use disorder in some countries, and the population-based interventions have more attractive ratios. So to sum up, this is some take-home points or messages. As we were discussing yesterday, the very conduct of these studies has value in the right context, because of the dialogue, the collaboration that is involved, and that brings up new conversations, new partnerships, new ideas. So that's good, but it's kind of time limited unless there is a place to position the findings of these analyses. Looking across the countries, the burden of the economically expressed burden of these conditions is quite consistent. It's something in the realm of 0.5 to 1% of a country's GDP. By comparison, if you look at it, express things in GDP terms, you'll see that the investment costs are about, around, let's say, 0.05 or 0.01% of GDP. So that's 10 times less. And when we monetize these benefits, they don't always, but usually exceed investment costs. And we have examples of where substantial gains can be had from really quite minimal investment. But as mentioned, there were some exceptions. And then just to, like any of these processes and efforts, there are quite a number of constraints and limitations. And the main three that we identified in this analysis, this article, first is of course around data, and there are many examples where we have to rely on international data, not just around things like effect sizes of interventions, but in many cases even the basic epidemiology of these conditions. I remember Uzbekistan doesn't have any psychiatric epidemiology data at all. So we had to completely rely on international data, which of course they weren't very keen on. So we had to then run an analysis without that, which was quite a challenge. So this is the first and major, perhaps, limitation. The second one, again, don't always have a good enough data around the the national level impacts of these interventions in terms of lost productivity, and indeed its restoration through appropriate intervention. So many of the clinical study, let's say for depression or anxiety, let alone or psychosis, they don't really measure economic outcomes. They look at clinical outcomes. They don't look enough at the impact of intervention, successful intervention, on economic outcomes like work productivity. So we ended up having to pull together what data we can from the international data and use that for these studies. There are some other issues around work productivity as well, particularly the absence of a method that we had come up with to quantify the long-term productivity benefits of intervening in adolescents and school-aged children. So if you improve or reduce the incidence of self-harm or depression, what does that do over time to their expected productivity levels in adulthood? And there are effects, and so far we didn't manage to include those in these studies, but Rachel Nugent and her team at RTI, as mentioned, have done a recent global ROI study, and they did find a way of doing that. So I think there's much to be learned from that. And the final one was around the, if you like, the selection of interventions. We've had a few instances where countries say, "Oh, can we look at the whole set of drug use disorders?" And unfortunately, we say, "Well, actually, no, we can't offer that because we don't have the interventions or even the whole disease programs plugged into One Health. We don't have a strong enough analytical basis to include these conditions." So that's the end of the kind of presentation of this comparative analysis. So take any questions on that, and then we could come back to any of these issues that were quickly raised on Tuesday, on the right hand side, but on Tuesday, and also yesterday. So many of the issues about the ICA and its place, how to maximize the implementation of the findings of these studies is still has been a big issue for these mental health investment cases as well. So maybe we come back to that. So I'll stop sharing and come back to the group here.